Today, we are talking about chronic obstructive pulmonary disease, or COPD. COPD is characterized by persistent airflow limitation that is usually progressive, and associated with an enhanced chronic inflammatory response in the airways and the lungs to noxious particles or gases. Patients who develop COPD have an enhanced or abnormal response to inhaling toxic agents. This amplified response may result in mucus hypersecretion, tissue destruction, and disruption of normal repair and defense mechanisms. These pathological changes result in increased resistance to airflow in the small conducting airways, increased compliance of the lungs, air trapping, and progressive airflow obstruction, which are all characteristics of COPD. Inflammation is present in the lungs of all people who smoke. This normal protective response to inhaled toxins is amplified in COPD. Two other processes involved are imbalance of protease and antiprotease, and oxidants and antioxidants. Inflammatory cells in the lungs include neutrophils, macrophages, and T lymphocytes. These inflammatory cells release a variety of cytokines and mediators. Increased production of proteases and inactivation of antiproteases results in imbalance. The previously mentioned pathogenic mechanisms result in the pathological changes found in COPD. These in turn result in these 6 physiological abnormalities. Because cardiac abnormalities clearly contribute to overall morbidity associated with COPD, an understanding of their role and potential for treatment is vital. The cardiovascular manifestations of COPD include right ventricular dysfunction, pulmonary hypertension, coronary artery disease, and pulmonary vascular disease. The pathogenesis of PVD and COPD is likely multifactorial and related to alterations in gas exchange and vascular biology, as well as structural changes of the pulmonary vasculature and mechanical factors. PVD increases morbidity and worsens survival. This association is likely related to the shared risk factors as well as similar pathogenic mechanisms such as systemic inflammation. Chronic hypoxia likely plays a role in the pathogenesis of PH in COPD by inducing vascular remodeling. It develops late in COPD at the time of severe gas exchange abnormalities. RVD is common in patients with COPD, particularly in those with low O2 SOTs. When present, it can reduce exercise tolerance, increase dyspnea, and contribute to overall decrease in functional status, and leads to higher mortality rate. COPD is an umbrella term that includes chronic bronchitis and emphysema. COPD is an umbrella term that includes chronic bronchitis and emphysema. A chest X-ray can show emphysema. A CT scan detects emphysema and rules out cancer. PFTs measure the amount of air you inhale and exhale, and how much air you can blow out. ABGs monitor oxygen and carbon dioxide in the blood, along with other parameters. These are the systemic features of COPD. Cachexia is the loss of weight, fatigue, weakness, and significant loss of appetite in a patient not trying to lose weight. In 2010, the cost of COPD in the United States was projected to be approximately $50 billion. Many patients who suffer from COPD lose time at work due to exacerbations, or can no longer work at all. Between the cost of healthcare and medications and the fact that many COPD patients have been disabled by the disease, many patients with COPD are unable to afford their medications every month. The one major, modifiable risk factor for developing COPD is smoking. CAPTURE stands for COPD Assessment in Primary Care to identify undiagnosed respiratory disease and exacerbation risk. It is a 5 questions tool along with peak expiratory flow meter test. Patients also should get flu and pneumonia vaccines, and quit smoking. Research into biomarkers are a hot topic in the effort to identify COPD early or even prevent it. Clinical studies are looking into antioxidants, such as broccoli extract, and certain genetic disruptors as new ways of treating COPD. The COPD gene study is looking for answers to why some smokers will develop COPD and others will not. In addition, 2 new non-invasive lung volume reduction treatment trials are being conducted. COPD is a serious disease and little research is being conducted to find a cure. Avoiding inhaling toxins is the greatest protection you can get for avoiding this progressive, terminal respiratory disease.